Hi, my name's Norman Wilson-Baig. I'm an ST6 academic trainee in anaesthesia with an interest in critical care medicine. So I'm going to talk to you about conscious proning during the COVID-19 period. Now, as you all know, proning is a common strategy that's used in the critical care setting. However, there is issue with the cumbersome nature of proning ventilated patients. This includes requiring 6 to 7 people to rotate the patient, the risk of the tube becoming dislodged, and then on top of that you've got the 16-hour proning period. There's risk of nerve damage, risk of pressure sores that can occur. So there's a good amount of close nursing and medical attention that needs for these patients. However, the benefit of proning in these patients is clear to see, and I'll explain a bit about that later on in this presentation. So naturally, wouldn't it be great if we can get the benefits of proning much earlier on in the condition? And I hope this will give you an insight from this presentation. So I'm going to talk a bit about the background, the physiology and rationale, evidence to date, a bit about the ICS guidelines, what we're doing here in the Northwest currently, and summarize at the end. So this is a bit about the brief pathophysiology. Forgive me if I'm teaching you to suck eggs here, but this is the traditional ARDS model. We have an insult. It's where the virus can cause an inflammatory change within the pulmonary tree, which causes increased permeability, which causes lung edema, which causes increased lung weight. That in turn leads to atelectasis, which leads to increased shunt and increased VQ mismatch, which in turn leads to reduced ventilatable lung, which therefore increases dead space. And so as you can see, there's like a cycle of destruction that occurs here within the pulmonary tree. The recommendations, or the way we sort of managed ARDS in critical care, is by using lung protective ventilation, by using PEEP to recruit the collapsed alveoli, and by prone ventilation. Now, you could be forgiven if you thought that even COVID-19, the kind of ARDS that we experience with patients attending the ED, would be very similar to what we see in the traditional type. However, this is not the case, and with experience we have seen that there's a different phenotype that, well, these have been anecdotally called the L phenotype. These are your sort of happy hypoxic patients who come in early within their condition. They're sitting in their bed or walking around within the room, happily conversing, using their phone, etc. And so this is a type of dysregulation of the pulmonary perfusion, which has been attributed to pulmonary microthrombosis. So these guys have the low elastance, which is high compliance, low recruitability. That's because their alveoli are pretty much open, and they've got a fairly normal lung architecture. Now, as the issue with these guys is that as the disease progresses and you get increased inflammatory changes that occurs within their lungs, these individuals then progress onto the H phenotype, which is what we're familiar with in the traditional form of ARDS. These are called H-type because of the high lung elastance, low compliance, a collapsed alveoli, therefore they're higher recruitability and they have a higher PEEP response. So what I must clarify here is that they're not two separate entities, but they're a spectrum of ARDS picture here between the L type and the H phenotype. And so it's the person who's coming through the door in the ED, it's unpredictable where on this spectrum they will be. What I will say, as Gattioni suggested, who's a well-known intensivist with a specialist interest in ARDS, is that when you're managing patients with the L phenotype, these patients require just increased FiO2 and liberal tidal volumes, unlike the H phenotype, which I've described in the previous slide, who need lung protective ventilation, etc. And so I hope this slide sort of clarifies that the COVID patients is sort of slightly different to the traditional type of ARDS. So a bit about the mortality. This information was taken from the economic data. So we've got non-COVID pneumonia versus COVID pneumonia. This was taken from 29th of May last week. The non-COVID data is from 2017 to 19. As you can see here, there's a stark difference in mortality between the non-COVID pneumonia and COVID pneumonia, between basic respiratory support, which is CPAP, and NIV, compared with the advanced respiratory support, which is intubation and ventilation. Now, if I was to show you this slide from a month ago, you would have seen that the advanced respiratory support in the COVID pneumonia group would have been around 66%. However, as you can see, it shows that we're obviously with more understanding of the condition, our management has improved. Obviously, there's a lot more improvement to go. So, what is the physiology of proning? Well, this is a slide to demonstrate that. You've got two pictures here in the supine and prone position. And on the right-hand panels, you've got the transpulmonary pressures and blood flow. So in the supine position, you've got increased transpulmonary pressures within the ventral alveoli, ventral side of the lung, and unlike in the dorsal side of the lung. And so what then happens is you've got this over-distended alveoli in the ventral side compared with the dorsal side. And then, the downside also is you've got increased blood flow going to the back of the lung. So you've got increased VQ mismatch, increased shunt, and so not ideal in ARDS, which actually worsens this position. In the prone position, as you can see, you've got more of an homogeneous transpulmonary pressure, and so what then happens in these individuals is that you get recruitment of the alveoli in the dorsal lung, and you've also got alveoli in the ventral lung, which is open as well. And interestingly enough, blood flow still preferentially goes to the back of the lung, and so guess what? You've got better VQ, you've got better shunt, improved shunt, and so hopefully better oxygenation. The theory behind this is evolutionary from our foreparents as we were primates, and we were on all fours, and so the most efficient way to ventilate your lungs was to, obviously whilst on all fours, is to make sure that the dorsal lungs are adequately ventilated as they have the better blood flow. So the benefit and the rationale for proning is that you've got recruitment of collapsed alveoli in the posterior lung, you've got improved secretion clearance and improved ventilation perfusion, and you've got reduced shunt as well. So we've seen the evidence for proning looked well in terms of the physiology and what we are doing within critical care. So I thought I'd just quickly show you the seminal paper as to why in critical care we use proning. So this is the PROCEIVA trial, which is the proning of patients with severe ARDS. This was done in 27 centres in France and Spain with a lot of experience in proning critical care patients. The primary outcome was all-cause mortality at 28 days. You can see the data's there. 16% mortality versus 33% in supine. And you've got the Kaplan-Meier curve on the right-hand side, which shows that in the prone group, the 90-day predicted mortality is much higher than that in the supine group. So the bottom line here is that proning in severe ARDS reduces mortality. However, as I said, it is a cumbersome procedure requiring multiple people to rotate the patient, risk of tube dislodging, etc., etc. So if proning is such a good thing in the critical care, but obviously considering the issues they have as well, wouldn't it be great if we can use the benefit of proning whilst a patient was awake, and therefore avoid the need for intubating these patients? So there's limited evidence for this, unfortunately, because let's face it, we always manage patients in a supine position. Scaravelli et al. In 2015 reviewed a retrospective study of 15 patients over a 4-year period. That's it, 15 patients they could find over a 4-year period that underwent conscious proning. And from those patients, they found that 12 patients were discharged and 3 unfortunately died. Then there's Ding et al. In 2020, Now, this was pre-COVID, and this actually tried to give it some sort of a formal study to it. It's a cohort study, but this looked at conscious proning with high-flow nasal cannula or NIV in combination, as opposed to conscious proning on its own. And over a year, between 2018 2019, they recruited 20 patients. And they found that 11 patients avoided intubation. And if, for those who'd like to know, NIV plus conscious proning did the best, while high-flow nasal cannula came at the bottom. The downside to this study is, although those 11 patients avoided intubation, which is great, the 9 patients that didn't avoid intubation actually had PaO2, FiO2 ratios of much less than 100. They were around 50 to 80. And so my feeling is that these people would have missed the boat with regards to conscious proning, because the ARDS at that point is quite severe, especially with values below 100. And then looking at the COVID era, you've got Sun et al. In 2020, who, from the experience of Jiangsu province, described that people who avoided intubation were those that actually they referred for conscious proning, and so they recommended conscious proning. And then there's Capito et al. In 2020, who recommended, who by necessity, conducted conscious proning in 50 patients in the ED, with the large number of patients arriving in the ED and the resources that were limited. And in their experience, 32 patients were successful and avoided intubation. And these were patients who they felt would have gone down the roads of intubation. And so in their experience, they feel that the conscious proning is a method to be. So these led us to the ICS guidelines, because there was an increase in appetite in the use of conscious proning. And so we've got here produced was the FiO2. We looked at patient selections is very, very important here. So the FiO2 we went for was at least 0.28, 28% oxygen, unlike previous studies which used 60% oxygen. Why consider proning when someone is on sort of higher oxygen levels, and the next level above that is a non-rebreathe mask? So we went for a lower oxygen requirement. Then it's important that these individuals are able to reposition themselves, able to communicate, because unlike the ICU, they're not going to get one-to-one nursing on the ward. Then the absolute contraindications are respiratory distress, obviously not going to make somebody conscious prone with a rest rate of 50 plus. And then relative contraindications, the one sticks out is pregnancy, but they can lie on the lateral. And then once they've agreed to conscious prone, then we look at the timed repositioning. Now this is table 1. As you can see, the time repositioning was considered within the DING study and also the Capito study. Let's face it, I challenge the most ardent person to try and sleep on their tummy for 16 hours. Unfortunately, there isn't a consensus on how long a patient should be prone. This is obviously being deduced with a meta-analysis, I think might be published next year. So we went with 2 hours fully prone, then lying on your right side, then left side, and then prone again. And the whole idea is to avoid lying supine, because there's uncertainty on the sustainability of oxygenation in the supine position. And so as you go on, you monitor the oxygen saturations in a particular position, and should they fail, then you can reposition them, or if they are deteriorating, then further help should be sought. So what are we doing in the Northwest? Well, in the Northwest, we're taking a pragmatic approach to that, looking at doing a prospective audit, examining the effect of conscious patients, and we're looking at the avoidance of intubation. We're looking at reduction in basic respiratory support, and FiO2 that's required. Safety outcomes, we're looking at the tolerability in those positions. And currently we have 70 patients that are being recruited so far. In another study, there's a French study looking at the which is PRO-COV study, looking at a single centre which are recruiting 25 patients, and we're awaiting their results. So to summarise, we can see proning is established in critical care and is very useful in managing ARDS patients. But the physiology suggests, although limited evidence is there, suggests that this is related to conscious patients as well, and hopefully would avoid intubation. Early evidence is that, as I said, it improves oxygenation, but we're uncertain about the sustainability when supine. Further studies are clearly needed, and obviously this is something to consider beyond COVID. I'd like to thank Dr. Andrew Bentley for kindly reviewing the slides, and also the Northwest Regional Group and Intensive Care Society for the publication of the guidelines, for which I'm one of the authors. These are the references. Thank you so much.